Melinda Mayorga, and I'm a clinical nurse specialist at the University of Southern California for ambulatory oncology services in the Norris Comprehensive Cancer Center. And so the interesting thing about gastroenterology patients is that they can be at risk for malnutrition even before they start treatment. So a bit of history, we partner with Anthem Medical Oncology Homes, and they provide a proprietary list of individuals who, based on their own analysis, determines who could be at high risk for readmission to the hospital within 30 days. And so when we looked at the list of those individuals who are at high risk for readmission, we began to note that there were many gastrointestinal cancer patients on the list. And so we thought, well, what can we do to intervene to prevent hospitalization for these particular individuals? And we decided to focus on nutrition. And so I partnered with our registered dietitians in our institution, and we decided that we would start by screening for malnutrition. Now, the hospital screens for malnutrition at the beginning of treatment and as needed. But we thought it would be more important to screen every single time the patient comes in. That's new. That's not something we were doing typically. So we used a validated malnutrition screening tool for outpatient oncology patients. And this tool asks two simple questions. Have you lost weight without trying? And has your appetite changed? Those two questions can identify if a patient is at risk for malnutrition. There are other tools, but we chose that tool. And the reason that we chose that tool is because we knew that our nurses would be administering this tool. And they have a very short period of time where they come and bring the patient into the exam area, and they have a very small time to do their initial assessments before they turn the time over to the physician or the provider to see the patient. So in that sense, we wanted to pick something that the nurses could easily do. So in our project, we identified that we have this group of patients who may be at risk for malnutrition. And we taught the nurses how to screen the patients. They had a paper screen, a piece of paper that they would ask these two questions. And if they scored a 2 or above, using the tool's metrics, if they had a score of 2 or above, they were going to be referred to a dietitian. The problem that we found, and the interesting thing that we found, is that it took 6 weeks for our dietary personnel to see these patients. So in 6 weeks, they could have already started treatment, putting them more at risk for malnutrition without ever talking to the experts about how they can manage eating during cancer therapies. So this was a profound finding. And we audited for, let me go back to that 6 weeks. So in that period of time, we found that we couldn't really support our findings. We were able to identify that about a third of our patients were screening positively for malnutrition. That's a lot in a 2-week period to find that. And so we, of those individuals, we were able to refer them to our dietitian. But again, it was taking 6 weeks for that individual to be seen. And as a result, we were able to determine that we needed more outpatient dietary support. And we were able to, many months later, defend and validate the need for a dedicated outpatient dietitian, which we now have a year later. So our little study helped that process to move forward, and we're just really proud of that. I think the implication is that we may underestimate the risk of malnutrition in specifically gastrointestinal oncology patients, but it could be with all patients. We know that we're going to change a patient with every treatment that we give, and so we need to make sure that our patients can tolerate their treatments by having the energy and the nutrition that they need. So asking a mere 2 questions can really begin a great partnership with our dietary colleagues and our physicians and providers who are providing, the treatment to get rid of this cancer. We need to make sure our patients are eating well and that we know what their risks are. And there's higher risk with different types of diagnoses, lower risk with other types of cancers. But we just need to be checking in with our patients. And we really underestimate how easy it is to screen for that. We need to make sure that we have the infrastructure to support it in our electronic documentation, and that the triggers that we build are easily discoverable by the people who can help our patients and can help them in a timely manner. That's really, really important. And that's what we found. We didn't realize it was taking quite so long for them to see our partners. We had it in place, but 6 weeks is a long time for an individual to wait. Well, I think that nursing is in a prime position to partner with colleagues within your institution to develop processes that can help your cancer patients. It's not just the treatment, but it's all the other aspects of cancer that place a person at risk for malnutrition, at risk for psychosocial issues, at risk for personal issues like financial toxicity, sexuality, caregiver issues. Those things are all important. It's not just the disease, but it's what the disease does to an individual and their families. And we have to be able to make sure that we're stepping up, that we're using all the tools that are available to us to make sure that journey is as smooth and uncomplicated as possible so that they can focus on healing and getting out of this cancer journey.